Hey. All right. Good afternoon, everyone, and thank you very much for joining us today for the third annual TSMA Medical Student Research Competition. My name is Adam Ahmed. I'm a third-year student here at CUNY, and for our new viewers, TSMA is the Thoracic Surgery Medical Students Association. We're a nonprofit, student-run organization which was founded with an ultimate goal of providing resources, mentorship, and network opportunities for students interested in thoracic and cardiovascular surgery. I do see a few familiar faces, so thank you for coming back to show support. The research competition has been a standing tradition of our group for a while. We hope that it would give students a chance to share some of the exciting things happening in the field while gaining some formative feedback in the process from an attending and resident panel of judges. This year, we received abstract submissions from 4 continents all over the world, and we're very fortunate to host 11 finalists today whose presentation stood out for not just amazing quality, but also relevance to the field. And we're also lucky to obviously host an incredible all-star cast of attending and resident judges, who we will now present one by one. First on the attending panel, we welcome Dr. Sarah Pereira, who graciously agreed to be a judge for a record 3rd year in the row now. Dr. Pereira is a professor of surgery at the University of Utah School of Medicine, where she also serves as the program director of their integrated and traditional cardiothoracic surgery training programs. Welcome back, Dr. Pereira, and thank you for answering our email every single year.
All right, next up, we would like to welcome Dr. Ahmet Kilic, who was also a judge at this event last year. And he is an associate professor of surgery and director of heart transplantation at Johns Hopkins Hospital. And he currently also serves as the program director of the Cardiothoracic Surgery Fellowship at Hopkins. So welcome, Dr. Kilic.
Next, we'd like to welcome Dr. Natalie Hua. Hopefully I pronounced that correctly. She trained in general surgery, cardiac surgery, congenital cardiovascular and thoracic surgery, and in surgical critical care. Dr. Hua has established herself in the field of cardiac critical care with a focus on adult congenital critical care, ECMO, mechanical circulatory support, and research in organ resuscitation for heart and lung transplantation at MGH before being recruited to Boston Children's Hospital. Thank you so much for coming.
Thank you.
Next up on the attending panel, we welcome Dr. Ali Rabi. Dr. Rabi is a cardiothoracic surgeon scientist in the Massachusetts General Hospital Division of Cardiac Surgery. He's a leading investigator in the Center for Transplantation Sciences at MGH, where he leads a team of surgeons and scientists to develop novel strategies to recover suboptimal donor hearts and lungs for transplant. Thank you so much, Dr. Rabi, for joining us today.
Thanks for having me.
All right, and next we would like to welcome our resident judges as well. First up, we have Dr. Ahmed Ali, a 3rd-year cardiothoracic integrated resident at The Ohio State University College of Medicine. And thank you so much for joining us. And then also in the resident panel, we have Dr. Do Nguyen. She's currently an integrated cardiothoracic surgery resident at the University of Michigan, where she also serves as chair of the Thoracic Surgery Research Collaborative. And she's currently on call right now, but hopes to join us during the second half of this event.
Thank you very much, Julie. And our final resident judge is Dr. Zach Brennan. He's currently a PGY1 integrated cardiac surgery resident at Cedars-Sinai. He's also running a little bit late, but he'll be with us shortly. And fun trivia, Dr. Brennan was actually one of the inaugural winners of the TSMA research competition, and now he's judging. So it's funny how time flies. Thank you all for being here. And as a brief overview, today we're going to play a pre-recorded video presentation for each of our finalists that will be summarizing their findings. This will be followed up by around 2 to 3 minutes of discussion time for each finalist with our judges. Andrew will be keeping track of time to ensure everyone has an equal chance of speaking. And after all 11 presentations have been played and all discussions have been had, we're going to tabulate the scores while Julie leads a Q&A panels session with our judges today. And with that, I think we can get started. I will pass the floor to Alice, who will present our first speaker.
All right, so first up, we have Christopher Kwan, who's currently an MS1 at Virginia Commonwealth University School of Medicine.
Sorry to do that over so I can share sound.
Good afternoon, everyone. My name is Christopher Kwan. I'm a first-year medical student at VCU School of Medicine in Richmond, Virginia. I want to thank the TSMA leadership, the research committee, and the panel of judges for the nomination and the opportunity to present our work today. Today, I'll be presenting our abstract titled Racial and Ethnic Disparities in Mortality Due to Mechanical Failures of Cardiovascular Implants and Grafts. We have no disclosures. As we all know, in the United States, heart disease is the #1 leading cause of death. As such, cardiac valve and revascularization procedures have been increasingly performed at higher rates every year. In this setting, several studies in the past decade have identified persistent racial and ethnic disparities in mortality that are related to heart disease and outcomes after certain cardiac procedures. With that in mind, we set out to examine the impact of mechanical failures of various cardiovascular valves and grafts on this apparent ethnic disparity. To do this, we conducted a cross-sectional epidemiological survey using the CDC Wonder database. We identified subjects with age ranging from 0 to 99 whose single cause of death is categorized by ICD-10 code T82. This allows us to identify all patients whose mortality was due to complications of cardiac and vascular prosthetic devices, implants, and grafts between the year 1999 to 2020. We analyzed age-adjusted mortality per 100,000 between various ethnic and racial groups that are listed here. We further stratified age-adjusted mortality by sex, age, and 4 U.S. Census regions. Our results indicate some positives, mainly that since 1999, age-adjusted mortality due to mechanical failures have been declining across all ethnicities. However, as it stands in 2020, we observed higher mortality among Black populations, equally both men and women, whose mortality has been disproportionately higher compared to all other ethnicities. This disparity was particularly more pronounced among the younger groups, or those under age 64, wherein their age-adjusted mortality among Black populations more than doubled that of their white counterparts. While overall mortality due to mechanical complications of cardiac surgery may have declined in the past 2 decades across all ethnicities, we've observed that Black men and women, especially those younger, continue to experience disproportionately worse outcomes. Interestingly, when we look at region-stratified data, Black populations in the southern states tend to experience this disparity more so than all other regions, while Asian Americans and Pacific Islanders tend to experience similar disparities in the western states. Now, our analysis is limited by properties that are inherent to the CDC Wonder database, mainly that CDC Wonder only captures aggregate death information. As such, we do not really have information on the decedents, individual information, that is. Mortality rates are also based on death certificate information, which are subject to misclassification. And finally, the ICD-10 code T82 certainly encompasses a very wide range of complications. There are several future directions we want to take this project. Mainly, we are actively looking into the role of socioeconomic status, hospital quality, and hospital-specific patient demographics on these observed disparities in outcomes. Certainly, due to the broad nature of ICD-10 code T82, further subgroup analysis into procedure-specific mechanical failures is warranted. And then from a health policy perspective, our survey adds to the growing body of evidence pointing towards the need to implement effective heart health and post-operative management programs that are designed specifically for Black and Asian American Pacific Islander communities. Thank you for your attention.
We will now take questions from the judges.
Yeah, hi, Christopher. Great job. I really enjoyed reading your abstract. I was wondering if in your subgroup analysis, if you found any significant difference between the mortality between Black men and Black women, and if so, what that difference was.
Thank you for your question. We actually did look at the differences between, we compared men versus women in each of the ethnicities, and there's actually no real difference there as far as we can tell from the CDC Wonder database. There is specific mortality that is specific to the mechanical failures of grafts and implants in general.
Was this a single center analysis? Can you just clarify that a little bit? And did you cross-reference with your STS data if it was your own data?
No, CDC Wonder is national. So any center can participate in reporting mortality that are based on their death certificates. So it's across the nation. We haven't cross-referenced it with the STS database, but that's what's on the docket next.
Great job on the presentation. I had a couple questions. So, do we know what the diagnosis for these patients is in terms of, a younger patient that comes in gets a valve or like a big aortic repair or something for a dissection will probably be different than an older patient who comes in for a regular aortic stenosis. Is that something that you guys accounted for in your studies?
So that's actually one of the limitations that because the CDC database just takes the aggregate death information, so we don't actually have the diagnosis information, and that's one of the limitations that we can't really parse apart, exactly what led to the mechanical failures.
All right, in the interest of time, I think we'll move on to the next speaker. Thank you, Christopher.
Awesome, great. Thank you so much. So our second speaker is Talia Median, who is an MS2 at Texas A&M School of Medicine.
Hello, my name is Talia Maidan, and I'm a second-year medical student at Texas A&M School of Medicine in Dallas, Texas. I am honored to have been selected to present my research at the annual TSMA research competition. I'll be presenting on the outcomes after coronary artery bypass graft versus percutaneous coronary intervention with or without the use of imaging in patients with multi-vessel coronary disease. I have no disclosures. Despite significant advances in revascularization strategies that have reduced morbidity and mortality rates in patients with multi-vessel coronary disease and acute coronary syndrome, the optimal therapeutic approach remains unknown. Thus, we sought to compare the outcomes of these patients. We performed a retrospective review of all patients with multi-vessel coronary disease and acute coronary syndrome who underwent CABG or PCI from August of 2018 through July of 2022 in a single healthcare system. Baseline patient data, procedural characteristics, and patient outcomes were assessed. Our primary endpoint was 1-year all-cause mortality rate. Secondary endpoints included index length of stay, readmission rates within 1 year, and myocardial infarction rates within 1 year. Of 1,854 patients, 16% underwent CABG, 14% underwent PCI with imaging, and 70% underwent PCI without imaging. CABG patients were significantly younger than PCI patients with a p-value of 0.002. 1-year all-cause mortality was assessed utilizing a Cox proportional hazard model with a random component to account for clustering within hospitals. This is indicated in the figure shown with highlighted p-values that show that CABG patients have significantly lower hazards of death compared to both PCI groups, while there was no significant difference in survival between patients who did and did not receive imaging. Index length of stay was evaluated utilizing a generalized linear mixed model. This showed that CABG patients had significantly longer lengths of stay compared to both PCI groups. When comparing PCI with imaging and PCI without imaging groups, there was no significant difference in index length of stay. Looking at myocardial infarction rates within 1 year, a Cox proportional hazard model was utilized. Treatment group did not impact myocardial infarction rates within 1 year, as indicated by the insignificant p-values. Looking at time to readmission, CABG patients had significantly lower hazards of readmission compared to both PCI groups, while there was no significant difference in readmission between PCI patients who did and did not receive imaging, similar to the assessment of mortality within 1 year. Our conclusions of this study are as follows. First, patients with multivessel coronary disease and acute coronary syndrome had low use of intravascular imaging overall. CABG patients had significantly longer lengths of stay compared to both PCI groups, which is expected given the invasive nature of the CABG surgery. CABG was associated with lower rates of mortality and rehospitalization compared to the PCI groups. Mortality was not modified despite use of advanced coronary imaging. This study is limited in that it is retrospective, and it does not investigate the specific parameters measured with intravascular imaging during PCIs. Looking ahead, we are working on collecting this data for this cohort to further understand the impacts of imaging and the specific imaging parameters on outcomes. Thank you so much for your time.
We'd like to open questions up to the judges.
Hi, Talia. It's nice to see you again.
Good to see you too, Dr. Pereira.
So I was interested in this study because, as you know, there are a lot of current multi-arterial grafting studies going on, particularly the Roma study in women, which we eagerly anticipate results. So within the CABG group, did you look at syntax scores to kind of stratify the severity of disease between the CABG group and the PCI group? And did you compare any baseline demographics like LV function, and then correlate that with a similar subgroup in the PCI group?
Yeah, those are all great questions. I think a big component that is lacking from this study is, or limiting this study is a lack of matching, right? We want to be able to incorporate that baseline characteristic matching a little bit more. Syntax scores are not always recorded thoroughly especially for CABG patients. So it's a little hard to collect that data within our institution, but we have STS scores. So that's something that could be maybe used alternatively. But it's a great note. And I think looking ahead, we definitely want to investigate more of the baseline characteristics. And when we're working on the paper now, and it goes into more depth on all of the baseline traits of these patients.
Great job. We all have to warm up a little today.
Talia, good job. This is a good, obviously relevant for all of us. But what do you mean by about imaging? What modality were you looking at?
Either IVUS or OCT. So we don't have specific data on exactly how big the distal reference area, all of the different measurements that come with IVUS and OCT. And my PI, Dr. Widmer, hypothesizes that if we understand more about how the imaging was done and if it was done thoroughly, maybe that thorough imaging could positively impact outcomes given the advancement of these imaging strategies over time. But it's either IVUS or OCT.
All right, I think we can move on to the next speaker. Thank you, Talia.
Thank you.
All right. Up next, we have Victory Effium, who is a current MS4 final year medical student at the University of Calabar in Nigeria.
Hello everybody, my name is Victory Effium. I'm a final year medical student from the Faculty of Clinical Sciences, University of Calabar, Nigeria, and I'll be doing this abstract presentation on the impact of cardiothoracic surgery rotation in Africa on the interest and perception of medical students towards a career in cardiothoracic surgery, a continental cross-sectional study. I'll be doing this presentation using the following outline: introduction, methodology, results, discussion, and references. By way of introduction, Africa is one of the continents with the highest number of cardiovascular diseases in the world, and with this, there's a looming shortage of cardiothoracic surgeons in this continent. A study conducted by Dominic Vervot et al. In 2022 showed that the availability of cardiothoracic surgeons per million of the population in North America and Europe is 10 times more than that in Africa. Hence, we decided to go with this study. Methodology. This study was an analytical cross-sectional study carried out on clinical medical students across Africa. across Africa. And then the data collection was using a 29-item electronic survey. Ethical approval was not required for this study, and data analysis was carried out using IBM SPSS version 26. Our inclusion criteria was all clinical medical students across Africa. And these clinical medical students are people from 4th year to 6th year. And our exclusion criteria were students, medical students in their preclinical years from 1st year to 3rd year. These were the results of our studies. We had about 527 participants from about 45 different African countries. 46.9% of these participants indicated that they did not have cardiothoracic surgery rotation in their hospital. 43.6% of these participants indicated that they had cardiothoracic surgery rotation in their hospital. Then we had about 55% of females who agreed that gender disparity was the reason why they're not considering this specialty as a future career. And this was after they had done the cardiothoracic surgery rotation. We also had about 63.1% of students that disagreed that cardiothoracic surgeons have a good work-life balance. And we had about 57.2% of females that believe that cardiothoracic surgery rotation had influenced their choice of choice of this specialty in future. And we had about 56.1% of males that believe that cardiothoracic surgery rotation had influenced their future career of pursuing this specialty as a future career. We did some correlational studies, and from our correlational studies, we noticed that students who had more than 4 weeks of cardiothoracic surgery rotation exposure were 1.75 times more likely to express a career interest in cardiothoracic surgery. And we also noticed that men were 3.22 times more likely than women to express an interest in cardiothoracic surgery career. We had certain limitations to this study while carrying out this study, which included language barrier, poor access to the internet or unstable internet connection, and we also, some of these questionnaires were distributed to specialty interest groups, which was created by a bias. We had no disclosures, and this is my conclusion. Cardiothoracic surgery rotation is a vital determinant in the perception and interest of medical students towards pursuing a career in cardiothoracic surgery. Our findings support the need for curriculum enhancement and standardization, increased exposure to cardiothoracic surgery, establishing mentorship programs, addressing gender disparities and societal perceptions, good work-life balance awareness, encourage subspecialty electives. These are my references. Thank you for listening.
We will now take questions from our judges.
Great job, Victory. Very cool presentation. Something that we're all aware of and has been kind of heightened with the recent publications that you've outlined. One of the things that we can probably all agree on spending our Saturday here is that cardiothoracic surgery is the coolest thing there's out there. The problem is the lack of exposure for people to see how awesome it is. Whether it's the inability to access cases or the inability to have mentors who can kind of show you the way. So in your study, what would you propose? Should we try to do some kind of regionalization of resources in Africa, which is a hugely underserved population as it relates to cardiothoracic surgery? Or if not, what would be your proposal?
I think first thing is the issue of when we carried out this study, we noticed that most of the centers or most of the countries don't even have cardiothoracic surgeons in the first place. Then we also noticed that most of them don't even have they only have like general surgery, which is just like a general kind of thing. So they just do rotation in those specialties. Then we noticed that for people that had the countries that had cardiothoracic surgeries, cardiothoracic surgery centers, they were not fully exposed. They lacked like certain facilities. So I feel like the major issue is like resource. We're having issue with resources. So like in my center, we hardly do a lot of CT surgery procedures. I'm currently at the CT surgery ward in the hospital. And then we have like, most times we don't have patients. Sometimes our patients are being sent because you don't have good facilities. You don't have enough facilities. Sometimes you send them out of the country. Sometimes you send them to like there's a particular center at Ibadan, where they send them to. So I feel like resources is like the major issue. Then I feel like for those countries that don't even have like a specialty, I feel like they should do like missions kind of model, like international community should come in and train surgeons in that field, and then those surgeons in that field can go ahead to train other surgeons. I think that's the way it can work out. Then if those countries can train those people, then we can now talk about resources. Like for a country like Nigeria, I feel like resources is the major issue. But countries like Cameroon, Tanzania, and other East African countries, I feel for those countries, they need people to train them in that specialty before having to talk about the resources, getting resources from the international community.
Yeah, it was an interesting presentation. I've published in a similar area related to increasing female interest in cardiothoracic surgery. I'm curious if you noticed that if you looked at interest before and after exposure to cardiothoracic surgery, and if you have any ideas on how to increase, because you mentioned that women have less interest. So if you had any insights into how to increase that interest in Africa.
Okay, I think one way to do that is through mentorship. Mentorship is a good way to increase a female exposure to that. And I feel like Africa as a whole, let me use Nigeria as a whole, we are still suffering the issue of some religion don't feel like ladies need to go to school. Yeah, so I think if that is even broken, if that issue is broken, then I feel like we have ladies more in any field, excluding cardiothoracic surgery. We'll have women in any field, and they will want to pursue that specialty. So I feel like one, mentorship; two, breaking the societal issues that we are having can help women pursue that career. That's for Africa that I know.
Thank you, Victory. I would like to move on to the next presenter.
Great, thank you so much. And so next we welcome speaker Lyndon Walsh, who impressively is an undergraduate at McGill University.
Hello, my name is Lyndon Walsh, and I'm an undergraduate researcher at McGill University in Montreal, Canada. Today I will be presenting our work on the effect of lobar versus sublobar VATS lung resection on patient quality of life. I have nothing to disclose. Currently, a hot topic in thoracic surgery is how much lung tissue to resect and which surgical approach to use. Recently, the Altorki paper from the New England Journal of Medicine and the Phase 3 JCOG 0802 paper in The Lancet found a non-inferiority of sublobar resections, that is, segmentectomy and wedges, when compared to lobectomies. In light of these novel data, we wanted to know if patient quality of life also had non-inferiority between these approaches to provide the thoracic community with alternative variables to consider when selecting a resection. To achieve this, we retrospectively sorted through an institutional database of over 1,300 patients and found 150 patients who had completed a preoperative and postoperative quality of life questionnaire in the clinic and underwent a video-assisted wedge, segmentectomy, or lobectomy. The two-part questionnaire consisted of the functional assessment of cancer therapy lung, FACT-L, which indicates better quality of life with higher scores, and a clinically significant threshold of 7 points. The survey also included the Edmonton Symptom Assessment Scale, ESAS, which indicates higher quality of life with lower scores and has a minimally clinical significant range of 1 point. Our population was 40% male, mean age of 67, and 71% stage 1 lung cancer. Questionnaires were completed on average 39 days before surgery and 33 days postoperatively. Results from the FACT-L questionnaire at the preoperative and postoperative time points found only one significance in the patients who underwent a lobectomy, and no change for the patients undergoing a sublobar wedge or segmentectomy resection. Notably, the lobectomy group is also the only group to achieve a clinically significant change greater than 7 points. Further analysis by grouping the wedge resections and segmentectomies together as sublobar resections similarly revealed no significant change. When looking at the ESAS results, the patients who received a wedge resection had no significant changes from pre-op to post-op. Patients receiving segmentectomy did exhibit some significant changes and significant increases in pain and fatigue. When analyzing the patients who underwent a lobectomy, we found the highest number of changes. They experienced significant increases in the symptoms of pain, fatigue, loss of appetite, feeling of well-being, and shortness of breath. It is likely that these increases are the driving force behind the clinically significant decrease exhibited in the previously mentioned FACT-L assessment. Subsequently, to ensure that this phenomenon was not driven by other factors, we evaluated the postoperative complications, length of stay, and operative times of every patient. There was no difference in postoperative complications between groups. Using regression models and Pearson's correlation coefficients, we found that these results were independent of length of stay and operative time. This leads us to believe that the results are driven by the type of lung resection as opposed to confounding variables. Our study has shown in a cohort of 150 patients that quality of life, as reported by the patient, is better preserved in VAT sublobar approaches as opposed to lobectomies. This is significant for the thoracic surgery community, as these data may suggest that sublobar resections can better prepare patients for a faster return to baseline after surgery. We recognize that further work in this field needs to be conducted, and we look forward to larger scale studies exploring this novel trend. I would like to thank Dr. Jonathan Spicer, Dr. Joseph Seitlinger, and Dr. Morgan Gold for their assistance on this project. Thank you for your attention, and I'm happy to answer any questions.
I'd like to open up questions to the judges.
So congratulations on doing this. I know you're probably the youngest in the group, and great job like starting your career this early. I mean, that's great. The one question I had was, when you were stratifying the patients for the study, did you look at like the pulmonary function tests, and did that affect how they recover? Because I know that sometimes, yeah.
Thank you for the question. We did evaluate all PFTs taken before surgery, and there is no differences between these patients that were evaluated.
Lyndon, that's a great job. Congratulations. I was wondering, do you know in your clinical setting if the surgeons manage their lobectomy patients any different than their sublobar resections? Meaning, do lobectomy patients get more chest tubes or epidurals in comparison to the sublobar resections?
That's a fantastic question. Thank you. So here at McGill, we have a pretty standardized protocol. So all the patients are on a ERP following surgery. Usually it's only one chest tube if they put a chest tube in. It's standardized between each of our physicians, and they tend to do it all the same way. So we don't believe that's a confounding variable in any way to this study.
Great job.
What's your next step? Congratulations on the study.
Next step for this project, I'm hoping to publish it, of course. I think that's the goal for all of us. But I would really like to expand this study. One limitation that I'm aware of, and I think you are as well, coming from Quebec, Dr. Waugh, is that many of our patients are only seen post-operatively about a month out because of our public healthcare setting. And so I'd really like to expand this study more longitudinally, and so we are able to collect more data for the thoracic surgery community. Because at the current moment, we have no data on quality of life comparing these resections.
Thank you, Lee. Sorry. Okay, I think we can move on to the next speaker. Thank you, Lyndon.
Thank you.
All right, next up we have Rachel Wolf, who is currently at The Ohio State University on a research year.
Good afternoon, everyone. Thank you to TSMA for this opportunity to present our research on the impact of permanent pacemaker implantation on long-term outcomes after transcatheter aortic valve replacement. My name is Rachel Wolf, and I'm a medical student at The Ohio State University. I'm excited to share with you our study today. In recent years, transcatheter aortic valve replacement, also known as TAVR, has emerged as a preferred alternative to surgical aortic valve replacement for treating aortic stenosis. However, this procedure has been associated with an increased likelihood of requiring a permanent pacemaker, and the long-term outcomes among these individuals remain unclear. Based on this, our study aims to directly compare the long-term mortality and post-operative outcomes between patients who required a permanent pacemaker implantation after TAVR and those who did not. We conducted a comprehensive retrospective review of 526 TAVR patients at our center who did not have pre-existing pacemakers. Age, race, gender, BMI, end-stage renal disease, STS risk score, diabetes, chronic lung disease, peripheral vascular disease, hypertension, cerebrovascular disease, heart failure, and a history of cardiac shock were used for a one-to-one propensity score match between the permanent pacemaker group and the non-permanent pacemaker group. Kaplan-Meier survival analyses and Wilcoxon tests were then performed to compare post-operative outcomes. Prior to propensity matching, the Kaplan-Meier estimated mortality showed no significant differences between the permanent pacemaker group and the non-permanent pacemaker group. This can be seen in the figure here. Additionally, our results showed that there were no significant post-operative complications between the two groups in the unmatched dataset. For example, as we can see in the table, the incidence of post-operative stroke was 2.91% in the non-PPM group compared to 5% in the PPM group. Similarly, the incidence of post-operative dialysis was close to 0%, and post-operative bleeding was about 3.8% in both groups. However, one key significant observation that was made was that the permanent pacemaker group had a significantly higher rate of hospital length of stay. After we conducted propensity matching, 80 patients remained in both groups. The groups are well balanced, and none of the variables used for propensity matching showed statistically significant differences between them. Similar to the results that were shown in the unmatched dataset, the Kaplan-Meier analysis for the matched dataset showed no significant mortality difference between the permanent pacemaker group and the non-permanent pacemaker group. This can be seen in the figure here. Additionally, our results showed that after propensity matching, there were no significant differences in post-operative complications between the two groups. Post-operative bleeding trended a little higher in the non-PPM group, but it still wasn't significant. Similarly, post-operative dialysis and stroke in the non-PPM group showed no significant differences when compared to the PPM group. Finally, consistent with the findings prior to propensity matching, there was a notable increase in post-operative hospital length of stay for the permanent pacemaker patients. To summarize, our study offers valuable insights into the long-term outcomes of TAVR patients with subsequent pacemaker implantation. Our findings indicate that the long-term mortality of patients undergoing TAVR was not significantly impacted by subsequent pacemaker implantation. This is an important finding as it suggests that the need for a pacemaker after TAVR may not adversely impact the mortality rates. Furthermore, despite a longer hospital length of stay in permanent pacemaker patients, other postoperative outcomes showed no significant differences between the two groups. In regard to limitations, the relatively small sample size of our study with only 80 patients undergoing pacemaker implantation may limit the generalizability. For future directions, there is a need for further investigation to identify risk factors that make certain populations more likely to require permanent pacemakers following TAVR. Overall, this data provides valuable information to practitioners and patients when it comes to navigating the complex and intricate aspects of TAVR. Thank you.
Like to open up questions to our judges.
Great presentation, Rachel. I really enjoyed it, and I suspect I put a couple of those TAVRs in during my time at OSU. One question I had for you is with regards to the type of valve placed. There's differences in pacemaker rates between the sapien valve, and those balloon expandable, and the Nitinol ones that are self-expanding. If you had any insights into those, as well as the generation of these devices.
Yeah, thank you. That's a great question. So for our study, we didn't look at different valves yet, but we're planning on doing a sub-analysis later. I know, like, after reading some literature, there was like indications that the different types of valves or like different indications are predictors of PPM implantation. So yeah, definitely would be a good thing to further look into.
Rochelle, I had a question about your follow-up for these patients. I'm trying to go back to your abstract and try to figure out what was your follow-up for this study?
So like we did at least 2 years for our follow-up. The maximum was 10 years. And basically like right now what we did was like for our registry, the form changed in July of 2020, and right now we're just currently chart reviewing for the rest of the patients up to December of 2022. So then we'll get more data with at least like 1 year post-op for everyone, and we'll add that to the study.
Great, thank you.
Mm-hmm.
Rachel, this was a great study. I think this is one of the first studies, and this is kind of my area of work, where people who've had permanent pacemakers independent of LVEF had no change in their mortality. And so I'm wondering in follow-up if you would consider looking at the D2 subgroup of aortic stenosis in particular. And those are patients that have more AFib, lower ejection fractions, that get TAVRs. And if indeed they have the same survival at 2 years as other patients, I think that's really novel information for the TAVR world.
Yeah, definitely. That's a wonderful suggestion. And I feel like that would be actually a great thing to add to like future research and future work, especially that focuses on a more in-depth analysis of, patient subgroups and risk factors for PPM requirement post-TAVR, and just follow that up.
Thank you, Rachel. I think we can move on to the next presenter.
Great. Next up is Amy Feng. She's an MS1 at the Johns Hopkins University School of Medicine.
Hi everyone, my name is Amy. I'm a first-year medical student at Johns Hopkins, and today I'll be presenting our group's work looking at the impact of COVID-19 on hospitalizations for infection following heart transplantation. We have no disclosures. Infection is a major cause of morbidity and mortality in heart transplant recipients. Furthermore, viral diseases affecting immune function have the potential to amplify risk of infection. Previous studies have investigated various risks associated with infectious complications following heart transplantation, but research into infections during COVID-19 remained limited. Thus, the objective of our study was to investigate the association between COVID-19 and hospitalizations for infection in the first year following heart transplantation. To do this, we used the UNOS OPTN registry and identified all adult patients who received heart transplants between October 2018 and June 2023. We further categorized transplants into 3 eras to account for both the October 2018 allocation policy change and the COVID-19 pandemic. The eras were pre-COVID-19, which was from October 2018 to March 2020, COVID-19 from March 2020 to March 2022, and post-COVID-19, which was from March 2022 to June 2023, with pre-COVID-19 being the reference group. For our analysis, we compared baseline characteristics and immunosuppression regimens between eras using descriptive statistics and hospitalizations for infection in the first year post-heart transplant between eras using multivariable logistic regression. In total, our study included 13,663 patients, 3,645 transplanted pre-COVID-19, 5,658 during COVID-19, and 4,360 post-COVID-19. There were significant differences in many of the baseline characteristics between groups, but I wanted to highlight a few in particular. Firstly, we found that recipient pre-transplant ECMO increased from 4.8% pre-COVID to 5.7% during COVID, and then 6.6% post-COVID. Secondly, median days on waitlist decreased from 42 days pre-COVID to 30 days during COVID, and 25 days post-COVID. Thirdly, looking at immunosuppression regimens, anti-thymocyte use decreased from 1.9% pre-COVID to 1.6% during COVID, and then 1.2% post-COVID, while use of basiliximab increased from 25.3% pre-COVID to 26% during COVID, before decreasing to 20.2% post-COVID. When looking at the effect of COVID on hospitalizations for infection in the first year after heart transplant, odds of hospitalization were 1.91 times as high during COVID compared to pre-COVID, and 4.37 times as high post-COVID compared to pre-COVID after adjusting for both recipient and donor characteristics and differences in immunosuppression therapy. In conclusion, the association between COVID-19 and post-heart transplant infection highlight a need to better understand the effects of the coronavirus pandemic on both transplant recipient immune function and their susceptibility to infection. Future studies should continue to investigate the factors and mechanisms that may underlie our findings. I'd like to thank my PI, Dr. Kilich, along with the TSMA for the opportunity to present here today, and I'd be happy to take any questions.
I'd like to open up questions to our judges.
Very well done. Congratulations. The couple of findings that you pointed out, including increased use of ECMO and decrease in waitless time, could also be explained with a increased use of DCD heart transplant. So, pre-COVID and post-COVID actually do correlate sometimes with those findings too. So not surprising there. The other thing I'm curious about is the hypothesis here is that somehow having COVID-19 or having contracted COVID-19 in the past as a heart transplant recipient will increase your chance of being hospitalized for an infection post-heart transplant. I'm just curious, what would be the literature background for that? Have you seen people talking about reduction in immune system after COVID-19? And if so, specifically to what type of pathogens, viruses, bacteria, etc.?
Thanks so much, Dr. Ravi, for your questions. Firstly, to address the DCD issue, that is something that I did run in an analysis, and it is definitely an important consideration that I'd like to look further into. Thinking about the hypothesis and what it means in practice, I think there are several theories that could come up. For example, one of them might be changes in healthcare practices, such as access to healthcare services, or changes with maybe modifications to infection control measures, hospital admission criteria. Another example might be behavioral factors, such as wearing masks or hand washing and hygiene. Something that I also think is interesting is thinking about COVID infection in these patients, because the dates were used for date of transplant. That could also, something that I'd like to look further into is if there's a way to create a reference group where it was impossible for any of the heart transplant recipients to have gotten COVID, in order to isolate for the effect of having possibly received COVID and how that might have affected post-transplant infections. But there is currently a dearth of literature on what the molecular basis might be, or specific viruses. And so I think that's definitely another future direction that we could take this into.
Amy, you did a great job, and you have an amazing research mentor. And I'm just wondering, and forgive me, I'm not a transplant surgeon, but does UNOS track how many of these patients actually had COVID and or the vaccine, that you could do a subgroup analysis to compare the rates of infection?
To my knowledge, no, there's not such data available, which is a limitation of the study. So that would be an amazing future direction also to take that into.
Yeah, I was going to ask the same question.
Thank
You
you,
would
Amy.
think they would, right, Dr. Kilich? It's an amazing show of infection post-COVID, which is similar to some of the pediatric oncology research that they're finding now.
Yeah, I wish we had more of a mechanistic way of explaining it aside from just describing it right now, but we're hoping that it maybe launches the next questions and answering with more granular data.
Thank you, Amy. I think we can move on to the next presenter.
All right, awesome. Great discussion. Our next speaker is Jonathan Zetto, who's currently a first-year medical student at the University of Pennsylvania.
Hi, everyone. My name is Jonathan Zito, and I'm a first-year medical student at the University of Pennsylvania. It's really great to be here today, and thank you to the TSMA Research Committee for putting this all together. Now, today, I'm presenting on my research looking at the usage of duplex ultrasonography when evaluating patients' radial artery suitability as a conduit during coronary artery bypass surgery, more commonly known as CABG. And in this specific study, we wanted to evaluate if there was any sort of association between preoperative pulmonary arch flow measurements and major hand ischemic events post-operation. So here's the basic introduction. At our institution, when evaluating the suitability of the radial artery for a CABG procedure, we measure the pulmonary arch flow before and after radial artery occlusion in the hand using duplex ultrasonography. And historically, our institution has actually avoided harvesting radial arteries in patients when we deem that the pulmonary arch flow is too low. However, this is based purely on intuition. It's not based on any sort of data or evidence. And there are actually no set guidelines currently in the field of cardiothoracic surgery for the use of duplex ultrasonography when determining radial artery suitability, which is what this project aimed to change. And so we wanted to do this study to, one, establish baseline flow characteristics to set a foundation for the creation of objective numeric-based guidelines in the future. And two, to retrospectively look at if patients who had low pulmonary arch or marginal pulmonary arch flow pre-operation, if they had any major ischemic complications post-operation. And so our cohort is just basically any patient who underwent a CABG with radial artery harvest from 2016 to 2023, because it was in this period that our institution started using radial arteries in low flow patients. And so once we got our patient cohort, we recorded patient flow characteristics and then sorted our patients based on their pulmonary arch velocity after the radial arteries occluded into these three categories: normal flow, marginal flow, or low flow. And so here on the right, we have a table of the flow characteristics of three groups. And some of the key takeaways from our patient analysis is that, well, one, there was no major ischemic events in any of the three radial artery groups. That doesn't mean that there was no major ischemic events at Penn for 7 years. We had a few major ischemic events. They just didn't happen in patients who underwent a CABG with the radial harvest. Two, the change in pulmonary arch velocity when the radial artery was occluded was actually much greater in the low and marginal velocity patient groups as compared to the normal velocity patient groups, but this wasn't too surprising. And three, now this was actually surprising. There was actually no significant difference in radial artery diameter or relative ulnar artery velocity augmentation between either of the three groups. And so some of the big takeaways that we took away from this study is that we believe, one, that patients with marginal or low reversal velocities in their pulmonary arches actually can safely undergo radial artery harvest without increased risk for major ischemic events. And this is actually really important because it expands the number of people who can have radial arteries harvested when undergoing a CABG procedure. And research has shown that the radial artery has better patency and long-term outcomes when used as the conduit as compared to like the saphenous vein. However, this project is far from finished, and we're currently working to expand our project by, one, looking at how preoperative flow characteristics associate with less extreme neurological symptoms, such as weakness or numbness. And we also want to use more objective tools to measure changes in hand function and capability post-operation, such as the grip test. Thank you for listening, and I look forward to hearing the other presentations.
I'd like to open up the questions to the judges.
I have a question for you. Congratulations on your eloquent presentation. I think it was really well organized. My question relates to who does the radial artery procurement in your institution, and do you have the plastic surgeons do it? Do the cardiothoracic surgeons, and what is the timing of it related to the procedure?
We have our PM and our department do it, and it usually happens anywhere from like a week to 2 weeks pre-procedure. Yeah, can you hear me?
Yeah, that's probably for the ultrasound, Jonathan. What about for the procurement, I think?
That's what I meant. Yes, thank you.
During the surgery, do you know who procures the radial and how do they procure it?
Um, sorry, that's what I was told who do it, but if it's not them, then I imagine maybe I guess radiology would probably do it then, but yeah, I'm also then.
Right. I think
Yeah.
I think you're talking about getting the velocities. We're asking about, or I'm not, but I am curious about who actually takes the radial artery out of the arm, which will then be.
Oh, my bad. Yeah, the cardiothoracic surgeon. Yeah, my bad.
That's a great job. Do you know if how do they decide not to use a radial artery? Do you know how many low flow palmar arches on studies were done that they actually decided not to? I mean, I would be hesitant to take a radial that was low flow. So it's a great research idea, right? And so I'm wondering how they decide to turn down a radial and not use it.
Yeah, I mean, like before 7 years ago, a lot of like we started doing more low flow here at our institution because a lot of the junior surgeons started to want to do it because they believed that they were low flow radial arteries were like an opportunity that weren't being used. And I think, as they might have mentioned in my presentation, it was just very arbitrarily decided that if it's too low, that we shouldn't do it. And then a lot of like other hospitals will do like an Allen's test to decide. And if you had a negative Allen's test, then you wouldn't have the radial artery harvested. But the problem with the negative Allen's test is that it's actually really not that sensitive to whether it's safe or not to harvest the radial artery. And so that's where this study like tries to come in and establishing more of like a more objective guidelines using Doppler flow analysis in order to determine like at what is there like a cutoff point where it's not really safe, or as long as like the pulmonary arch flow is not zero, can we still use it?
All right. Thank you, Jonathan. I think we can move on to the next presenter.
Great. Next up, we have Shiv Verma, who is currently taking a neresearch year at the Frank H. Netter School of Medicine at Quinnipiac University.
Okay, good afternoon, everybody. My name is Shiv Verma, and I'm a third-year medical student at the Frank H. Netter School of Medicine at Quinnipiac University. And I'm also a member of the cardiac surgery outcomes group at the Yale School of Medicine. So what I'm presenting today is our study on the midterm outcomes of a concomitant CABG within ascending aortic aneurysm repair. And so to give some background, ascending aortic aneurysms are highly associated with coronary artery disease with an aneurysm repair oftentimes taking place with a CABG. And so previous studies that have investigated concomitant CABG with an ascending aneurysm repair have shown variable results, with some showing that there are increased risks to adding a CABG and some showing that there aren't any differences in risks when you add a CABG. So in our study, our goal is to compare early and midterm outcomes of an isolated aneurysm repair with those of an aneurysm repair with a concomitant CABG at our institution. So what we did was a single center retrospective matched cohort study where we had one cohort of 35 patients who had a concomitant CABG with an ascending aortic aneurysm repair, and another cohort of 34 patients who had an isolated aneurysm repair. We then compared data on demographics, comorbidities, intraoperative details, and also short and midterm outcomes. So the first thing we found was that adding a CABG was associated with significantly longer bypassing cross-clamp times, then also a longer length of stay. And what we found was that neither group had any intraoperative deaths or any other short-term adverse events. And we also found that the need for RBC and platelet transfusion, intubation time, and length of ICU stay didn't differ significantly between the two groups. So next, we generated Kaplan-Meier curves to compare survival between the concomitant CABG group and the isolated repair group. And the mean follow-up time for the whole cohort of patients was 2.3 years. What we found was that there were 2 late deaths in the CABG group. One patient died from external wound abscess and another from COVID-19 pneumonia. And so for the whole cohort of patients, survival was 99% at 1 year and 96% at 3 years. And upon log rank sum analysis, we found that survival didn't significantly differ between the two groups, with 93% of CABG patients and 100% of isolated patients surviving by the 3-year follow-up time. And we did the same thing with Kaplan-Meier curves comparing reoperation between the two groups. We found that 3 patients in the isolated repair group underwent TVAR for type B dissection. For this whole cohort of patients, the freedom from reintervention was 97% at 1 year and 94% at 3 years. And just like with survival, we found that freedom from reintervention didn't differ significantly between patients with and without CABG, with 100% of the CABG patients and 94% of the isolated repair patients being free from reintervention by the 3-year follow-up time. So in conclusion, we found that a concomitant CABG wasn't associated with increased risks for operative mortality or morbidities, and that the CABG patients had comparable midterm survival and freedom from reintervention rates as the isolated repair patients. And so overall, our findings suggest that a CABG can be safely done with an ascending aortic aneurysm repair when it's needed without any increased risks. And that is all. Thank you.
Okay, we'd like to open up questions to our judges.
Shiv, congratulations on this study. Can you comment as of the ejection fraction pre and post for the groups, whether or not they were similar and
Sure, thank you for the question. So we actually didn't record LVEF as a variable in this study. So I wouldn't be able to comment on that, unfortunately.
Well, great job. Wonderful presentation. One of the things that I think is difficult in answering a question like this is that you're looking at 2 pathologies instead of 1. And for you, that's combining coronary artery disease with aortic aneurysms and comparing it to just aortic aneurysms themselves. So perhaps having a little bit more granularity on the complexities of the operation will be very helpful, like the number of grafts that were bypassed and things like that, because it's very different to do a 7-vessel bypass and an aortic aneurysm and a single vessel bypass. So maybe worthwhile to do that and see what the effect of that is on things like cross-clamp times and transfusions and things like that. But really well done, and congratulations on the study.
Thank you so much. Those are great suggestions.
Shiv, I would also be interested in knowing the sizes of the ascending aortas that you guys are doing. And because usually the question's kind of flipped. Usually you go in for the CABG and then you have the ascending aortic aneurysm that you're trying to fix. And the question is some aortic surgeons are more aggressive than others, depending on the size of the aorta. So, and that's where the whole, should I do the ascending aortic aneurysm on top of the CABG question kind of comes in. So excellent study. The question itself, I think, probably has to be flipped. And then I would talk about the size of the aortic aneurysm. And as Dr. Kilich mentioned, also the, we go into a bit more detail about the CABGs.
Definitely. Thank you for the suggestions.
I'm repeating a question that Dr. Chikwi asked a different person last year during the same competition, which makes sense considering she's my boss's boss. But do you think that there is no difference in survival among the groups, or do you think if you had maybe twice the number of patients, do you think it would be the same outcome? And it's okay. I don't know the answer. I'm genuinely asking what you think.
Right. So that's definitely a suggestion for an expansion of the study. Ideally, we want to incorporate more patients. We also want to incorporate long-term outcome data. So beyond the 2.3 year mean follow-up time, and seeing if there's any changes in mortality if you sort of, look years down the line. If we were to add patients, I mean, it's possible there could be a difference. It is a little difficult to say. We were limited with how many concomitant CABGs were done with the aneurysm repairs at our institution. So we kind of went with what we have, but so far it's tough to say whether there is that, direct lack of a correlation, but, adding more patients would definitely be the good next step.
Great presentation. Thank you.
Thank you.
One quick note also, I noticed there were quite a few of those patients that had hemiarches, which I assume were circa-arrest case hemiarches. And I think in your final data manuscript, it would be interesting to look at the circa-arrest times and the CABG versus just the ascending patients, and if there was any difference in, mortality or comorbidity with those patients.
I see, definitely. Thank you.
Thank you, Shiv. We can move on to our next presenter.
All right, our next presenter is Andrew Morse, who's currently a second-year medical student at UT-HSC Houston McGovern Medical School.
Hi, I'm Andrew, and today I'll be talking about the complications and outcomes of veno-arterial versus veno-venous ECMO in pediatric and neonatal patients. Before we get started, none of the authors have any financial relationships or affiliations that we need to disclose. My ultimate goal with my talk today is to convince you of the safety and efficacy of VA ECMO in comparison to VV ECMO. To do this, I'll start by discussing the different utilization of VA and VV ECMO historically. I'll describe our center's experience and results in the last 10 years, and I'll point out a few key limitations before discussing our conclusions and their implications for the future of pediatric and neonatal ECMO. Over the last couple of decades, the use of ECMO in pediatric care has increased quite a bit, with around 1,700 total runs being completed in 2007 to over 7,000 runs in 2023. With this pretty marked increase in use, the total overall survival has still hovered around 60%. When comparing the two ECMO modes of support, VA, which supports both the heart and the lungs, and VV, which supports only the lungs, we can see from the ELSO data from 1989 to 2023 that VA ECMO is associated with a significantly increased rate of bleeding complications and a lower rate of survival to discontinuation of ECMO and to discharge. This has resulted in VA ECMO being reserved for use in patients that have proven hemodynamic instability or cardiac dysfunction and therefore absolutely require the cardiac support that is offered by VA ECMO. Our hypothesis is that recent advancements in circuit technologies, anticoagulation strategies, and patient management have made VA ECMO as safe as VV ECMO and should be considered in a wider range of cases. To evaluate our hypothesis, we conducted a retrospective chart review from 2014 to 2023, in which we identified 87 total ECMO patients that were cannulated at our center. Of these patients, 49 were pediatric and 38 were neonatal. We saw 80 patients supported with VA ECMO and 7 that were supported with VV ECMO, and over the course of their ECMO support, 8 of our patients were ultimately safely converted from VA ECMO to VV ECMO. In comparing the complication and survival rates between VA and VV ECMO with patients at our own center, we saw no significant difference in the rate of bleeding complications, neurologic complications, survival of ECMO, or survival to discharge. However, this direct comparison is somewhat limited by the low number of patients supported with VV ECMO. We then turned our comparison toward the ELSO database, where we can see that the rate of bleeding complications with VA ECMO at our institution was significantly lower than that reported by the ELSO, and the rate of neurologic complications and survival was similar. Another important and notable comparison is that the rate of bleeding complications on VA ECMO at our center was not significantly different from the rate of bleeding complications on VV ECMO as reported by the ELSO. Before discussing the conclusions we can draw from these results, it's pertinent to acknowledge the limitations that arise from the fact that our study and data are retrospective and from a single center. We have relatively few outcomes and a particularly small number of patients that were supported by VV ECMO, which somewhat limits our direct comparison between patients at our own institution. When comparing with the ELSO, there is a lack of a clear and standardized patient risk stratification, which means that it can sometimes be difficult to separate the risks of a particular ECMO mode of support from the risks of the critical condition for which that support is required. This would likely explain the lack of a survival advantage we would assume would be conferred by our center's significantly lower rate of bleeding complications. With those limitations having been acknowledged, we can confidently conclude that VA ECMO is as safe and effective as VV ECMO in the pediatric and neonatal patient cohort, and that because of this, patients with a predominantly respiratory indication and any signs of cardiac instability or hemodynamic lability should be cannulated on a VA ECMO first before safely converting to VV ECMO when clinically indicated. Thanks so much, and I look forward to answering your questions.
I'd like to open up questions to our judges.
Andrew, I think it's important. So I'm just by I'm a congenital heart surgeon, and I do congenital cardiac critical care. So I think, in presenting this data, and some of the data is in your abstract, but it's important that you talk about the indications for which, because if you're supporting a patient after cardiac surgery or for diaphragm, it's different indications, and the therapy is going to be different. So I think that I think that that's really important as you're like, you know, in your introduction slides that you clarify that, obviously, because if you're not supporting the patient with a proper technology for the proper indication, of course, the outcomes are going to be different. So that'd be just my first comment. In your paper, in your abstract, you do talk that the majority of the patients were supported for cardiac indications, but I was wondering if you have a little bit more details, if it's post-cardiotomy versus, you know, sepsis with cardiac dysfunction. If you could
Absolutely. So we ran into a little bit of the time crunch with just a 4-minute presentation, which is why we elected to leave that out. To answer your question, about 22 of the 87 were cannulated or converted to ECMO after bypass, after being unable to separate from bypass, whereas the remaining 65 were either with a residual cardiac defect that they were being readmitted for, or a primary cardiac defect that they were having to be stabilized pre-op for. Only 2 had a primary respiratory indication, both of which was just PPHN, persistent primary hypertension of the newborn. But again, we see a clear vast majority supported for cardiac indications with VA ECMO at our center. And kind of the direction that we're taking with this and the way we're trying to argue and present our data is that VA ECMO, while previously being associated with that increased rate of bleeding complications, is not anymore. And so that's not something that needs to be considered in a case where we have maybe a primarily respiratory indication, but there's some sense of hemodynamic lability. We don't need to be as afraid going forward to put that kid on VA ECMO first before converting to VV ECMO when it's clinically indicated, if that sort of gets at your question.
Yeah, I think it's going to be quite important to do these subgroup analyses because if you're putting the patients on ECMO post cardiopulmonary bypass, I mean, these are, you know, in general, the patients that end up with a lot of bleeding and complications and less optimal outcomes versus other indications such as myocarditis.
Absolutely. Thanks so much.
Thank you, Andrew. We can move on to the next presenter.
Great. Next up, we have Michka Mohammadi, an MS2 at Oregon Health and Science University.
Hello, everyone. My name is Michka Mohammadi, and I'm a second-year medical student at the Oregon Health and Science University. I want to firstly thank TSMA for the opportunity to present my group's research and to the esteemed panel of judges for their time. Today, we'll be discussing EHR signaling data from the Department of Surgery. We have no disclosures. The electronic health record is a central repository for data that drives patient care. As such, patient care is intrinsically influenced by a user's ability to efficiently navigate within the EHR system. Variance in individual usage patterns and EHR training has contributed to varying levels of safety performance and mortality outcomes. We aimed to explore the EHR usage of various training levels within the Department of Surgery by both tool and data type, as well as time of use. We hypothesized that residents would have a more diverse usage of the EHR in comparison to attendings. For our methods, we identified individual user-level data from our institution ranging from March of 2023 to March of 2024. These were collected and analyzed. We looked at length of time spent per day, day of the week, the EHR category, and the proficiency score. Users were then grouped into surgical attending or surgical trainees, and averages were calculated. The mean EHR time trends were similar among trainees, the target group, and the attendings, the compare group, with Saturdays being the highest day of usage, with 69.5 minutes spent for trainees and 41.2 minutes spent for attendings. Peak usage for trainees was between 600 hours and 1,300 hours, with 4.4 to 4.7 minutes spent per hour. For attendings, they had 2 specific time periods, 700 hours to 900 hours and 1,300 to 1,400 hours, with 2.6 to 3 minutes spent per hour. The average attending usage time was consistently 2/3 less than that of trainees. The proportion of time spent on EHR activities did not differ by day. The other activity, or notes, were the most time-consuming, followed by order management and chart review. The other category consists of care plans, slicer dicer, medication administration, allergies, problem lists, and more. Here we have a chart breakdown over the course of the year with note speed, chart closing delays, seconds spent per completed message, and our proficiency score. Here we can see that the note speed is consistently less for our target or our trainees. They have a higher delay in chart closing per day, as well as more seconds spent completing messages. Overall, their proficiency score was lower than that of our attendings. In conclusion, our trainees spent more time using the EHR in comparison to our attendings, but the proportion of time spent on different activities was similar. These differences may be explained by differences in patient load, EHR duties, or even potentially efficiency navigating the EHR system. Future projects should focus on comparing these metrics across specialties due to the possible varying needs of each department. But more importantly, this study highlights the time burden of note-taking, emphasizing a future EHR improvement of streamlining documentation to reduce provider fatigue. Thank you for your time.
I'd like to open up questions to our judges.
Michka, this was a great presentation and a really interesting research question. I think some of it's common sense that we know that trainees spend way too long on Epic, but did you look at the different surgical subspecialties and determine, which groups of surgeons in our specialties are spending the most time on Epic and which are spending the least?
Thank you so much for your question and your kind words. That's our next step. So we're going to be dividing into subspecialties and seeing exactly which specialties are spending more time, utilizing what tools, and just overall across Epic.
Congratulations, Michka, on a great presentation. One of the areas of controversy / debate recently is the use of EMR and physician time during off hours, and whether or not this should be something that's a billable service to actually patients. It's a little bit of a dangerous thing to start keeping track of here, but what do you think should be some safeguards that we put into looking at data like this and kind of protecting patients from having too many bills to pay?
That is a very interesting question. I definitely don't think that patients should be paying for more billable hours. What I think would be a better use of our research would be to actually find a way to streamline EHR documentation to reduce the amount of hours residents and attendings need to be spending on Epic. This is where things like AI potentially coming in as a chart using tool might be beneficial, or even looking at training medical students in EHR sooner so that people become more proficient in their Epic training abilities would be a better use of time instead of putting this all on the patient.
Thank you so much, Michka. I think we move on to our next presenter.
All right, our last presenter is Tiffany Yuga, who's currently a third-year medical student at Stanford University.
Hi everyone, my name is Tiffany Yu and I'm a third-year medical student at Stanford University. First, just wanted to say thank you to everyone who helped put this event together. So I will be presenting on our project entitled Combined Breast and Lung Cancer Screening Among Dual-Eligible Women, a Descriptive Study. We have the following disclosures. So lung cancer is consistently the leading cause of cancer death among women in the US, and several large randomized controlled trials have suggested that women undergoing lung cancer screening may have a greater mortality benefit compared to men. We implemented a pilot dual screening program that paired together screening mammography, which has consistently high uptake rates, with lung cancer screening, which has consistently low uptake rates. And our aim with this descriptive study was to assess the characteristics and attitudes of patients enrolled in our dual screening program. This was a prospective study conducted at 2 academic institutions. and it carried out over the course of a year. Briefly, in terms of our workflow, we identified patients who are scheduled for screening mammography and determined potential eligibility for lung cancer screening based on information in the EMR. We emailed our first survey to these patients, and that survey queried their demographic information and smoking history. We then determined eligibility based on the most recent USPSTF guidelines, and eligible patients were enrolled and sent a second survey, which queried knowledge, attitudes, and perceptions about lung cancer screening. They were then set up for a shared decision-making visit, at which time they were educated about lung cancer screening and its risks and benefits. And those who elected to proceed underwent a low-dose CT scan and received the final survey in our series, which essentially asked about their experiences going through our screening process. So in terms of results, our participants had a median age of 57. They were all female, majority white, majority had a college education or higher. A minority had a personal history of COPD or emphysema. Most, in terms of smoking history, most were former smokers. The median age at which people started smoking was 16, and the median pack years was 36, which is quite a bit above the minimum of 20 required to be eligible for lung cancer screening. In terms of knowledge and attitudes prior to the intervention, more than half of participants did not know that lung cancer screening was recommended for some high-risk smokers. There were overall favorable views about dual screening, and most questions that people had about screening were really about logistics of the how and when. Continuing with our pre-intervention surveys, we saw that about half of participants were worried about cost of screening, and almost all felt that they were at risk for cancer. In terms of motivations, most were motivated by early detection and treatment of potential cancer. And then in terms of post-screening surveys, we saw overall favorable perceptions about the shared decision-making visit and the screening process. In terms of conclusions, so our study participants of women who currently or formerly smoked represent a high-risk yet under-screened group. And these are women with significant pack year histories who felt that they were at risk for lung cancer but had never been screened before. There are likely many reasons for that, but our survey results highlighted the important barriers of lack of awareness and knowledge about lung cancer screening, as well as concerns about associated costs. At the same time, these women were overall highly interested and motivated to get lung cancer screening. And encouragingly, we found that after undergoing screening, interest levels in screening and satisfaction levels with our pilot program were also high, suggesting that pairing breast and lung screening together is a feasible and acceptable intervention that can help to increase lung cancer screening uptake among women in the US. In terms of limitations, I think the biggest thing for us was our small sample size and the loss of survey participation later on in the screening process, which may have skewed our results about post-screening perceptions among participants. And finally, in terms of future directions and ways that we can work towards increasing lung cancer screening uptake and decreasing lung cancer-related mortality, first is increasing patient education around lung cancer screening, who should get screened, why it's important, how it works, and second, developing a dual cancer screening model that can serve as a widely adoptable framework for other institutions. Thank you.
We'd like to open up questions to our judges.
Hi, Tiffany. That was a great job. I'm curious, did you have any insurance issues with having lung cancer screening and mammography covered in these patients, or was there any barrier to having the studies done?
So that was not an issue we encountered, but I think an interesting thing that came up in our surveys with patients were concerns about costs, because lung cancer screening should be covered for patients, at least under Medicare, Medi-Cal, for those who qualify per the USPSTF criteria. So I think that was an interesting kind of knowledge gap or knowledge barrier that we found. And so we feel like something that would help in the future would be kind of clarifying that issue of cost for providers to do with their patients. I don't know if that answered your question.
Yeah, no, that's great. I think it's, for coronary calcium screens and lung cancer screens, I think patients don't want to come in because they feel like they'll have a cash bill and then it's not covered.
Yeah, I mean, I think certainly there are, in addition to the cost of the screening itself, there are costs with transportation, missing work for people. And I think our population was sort of selected among people who are already undergoing mammography, kind of with the assumption that they had some form of health insurance. And so I think we did miss out on that part of our population that doesn't have regular healthcare and maintenance, and for whom cost may be a bigger concern.
All right, if there are no further questions, I think we can conclude.
All right. Thank you all so much for those incredible talks and presentations and discussion points. I know I definitely learned a lot and I have a lot to read up on after this. But congratulations to all of you. And there's no round of applause on Zoom. I wish I could do the clapping emojis, but I haven't figured out how to do it yet. In the interest of time, while the committee tabulates the score, I think Julie could help lead a Q&A panel with our judges. And we'll be announcing winners very shortly.
Yeah, thank you so much, everyone, for amazing presentations. Seems like we have students from all stages here, right? Students who are newer, students who are farther along. So we were just interested if any of our judges on the call had any advice for students who may be new to research in general. Say somebody is interested, but having a hard time finding a lab or mentor, either at their institution or elsewhere. Any judges on the call would have any advice for these types of students, finding a mentor or finding a lab to get involved with as they start their research careers.
I would say I think all of you did an amazing job finding mentors and research projects. I imagine that the gentleman from Nigeria that did a great job, that resources would be more limited for our international medical grads. But I would say reach out and find mentors and keep up your projects and go from there. This was really impressive. This is the third year I've done this, and I think each year the presentations have become so much more polished with great research questions. So good job.
I agree. I think this is only the second year I've done it, but I agree that the presentations keep getting better each year. One thing I will say about research that's a little bit different is that you have such a wider reach nowadays than you used to. You used to be kind of stuck at your own institution, and now, I'm looking across the grid here, and there's so many faces that you can reach out to as co-students and co-judges, where if you don't have somebody at your institution that can help you, you can reach out fairly easily. And a lot of the research can be done remotely using national databases and things like that. So I'd encourage you to use this network, the TSMA and others, to get connected and just look at science and research and get geeked up about it.
This is my first year judging, and I was also extremely impressed with the presentations. I think there's also a lot of programs now for students through the different professional organization in CT surgery, either for going to a conference or even for summer research. And so I think that's really important for your career, because it's going to help you help you get more attention as you're, growing in that field. I would also say that even if cardiothoracic surgery is a long road ahead, it's really important to spend some time and carve some time to do research at different times in your career, so that you can sort of like sophisticate your thinking and innovate in the field. And I just encourage everyone to reach out if they have any questions.
A little plug for all of our scholarship programs. I think that there are so many great programs through Women in Thoracic Surgery and STS, as well as AATS, and you're all at the perfect levels where you could apply to any of those. I would encourage you all to go to the websites for all those organizations and apply. That's how I met Talia at STS this year. And, I think you're all highly qualified, and it's a great way to network more at meetings and meet more people.
Great. Dr. Garrett Walsh, I see your hand is raised. Feel free to unmute and if you have a question. Alrighty, we'll move on to our second question then. let's say, for those of the panelists and even the residents as well, when looking back during your research time, either during medical school or now currently in residency, what are some things that you wish you would have known, or what would you have done differently now that you're kind of at your stage looking back? Is there anything you would have done differently, or advice that you would give all of us as we start out?
You get asked this question all the time, and the answer I think remains the same, which is to enjoy where you are in life. Oftentimes in medicine, we're looking ahead. You're a first-year medical student, you can't wait till being a third-year medical student and starting clerkships. When you're a third-year medical student, you can't wait to do sub-Is as a fourth-year student. Then it's, hey, I can't wait to carry the intern pager, and next thing you know, you're in your 40s. So just relax. You guys are all just brilliantly accomplished. I mean, you guys are so smart. Just enjoy the moment of being through medical school, and don't sweat this small stuff. You're going to be more successful than most of the people. You're surrounded by people who are like-minded and enjoy taking care of people and asking research questions. So just take it a little bit easy on yourselves, and just know that you're in good company.
It's great advice. We had a TMSA webinar last night with WTS, all women, and the exact same answer came from a lot of really elite panelists of women surgeons around the country of, careers go really fast. I mean, I look at it now, I'm in my 50s and I'm like, where did it go? And I wish I would have paused and enjoyed more at each step of the way.
I think one thing I would say specifically about doing research and having a career and thinking about your specialty and subspecialty, it's always helpful to do research in what area you're interested in. Seeing the patients and then going to the lab, or analyzing the data pertinent to the patients you see every day is helpful, and you get sort of a added energy when you see the patients in clinic, and I think it gives meaning to the research you do in a significant way.
Zach and Ahmed, do you have any tips for all these students of how you did it and got into great residency programs and how you built your CVs for your applications?
Sure. So I think people talked about the look into the future and Member for a Day. I really recommend those. I had both of those. They were both excellent experiences. And there are other, STSA has one, like all these organizations have them. So find them and apply. Those are really great experiences. I think as far as research goes, I think something that I thought I did research at the University of Florida over a summer, and I had funded research, and I was like, oh, it's all about the publication at the end. But at the end of the day, it was actually way more about building relationships with mentors and sponsors who truly made my career possible. Obviously getting publications is great, but I think building those connections with strong mentors and sponsors that will, be on a meeting with an attending at a program maybe you want to be in residency at, and say, hey, Zach has great hands, you should take him in your program. Like, that's a huge thing. And so don't neglect those relationships. And I definitely would not be here without excellent mentorship. So
my path was slightly different. I actually started as an MD PhD student, and navigated my way towards surgery. And I think really the key things for me were the mentorship and the exposure. Were the two main things. And kind of to your earlier question before, we always talk about, finding mentors, but one really important thing is also figuring out how to be the best mentee possible. And there's a skill set there, and I think you guys already have it. I mean, you guys have managed to get mentorship and work on a project and follow through with results. So yeah, so continue doing that. But I think key thing is mentorship and exposure, and finding a generous mentor who is willing to give you time to really show you the path, and to to keep you from wasting your time on other routes that might not lead you to where you want to be.
All right. Thank you very much for those answers, and to our judges for being here today. I know some of you are currently on call, or if not, this is one of your rare afternoons off. So we really appreciate you taking the time to be with us and show support for medical student education. We do have our 3 winners ready to be announced, so I'll pass the mic to Andrew, who will be announcing our 3rd place winner.
Thanks, Adam. So our 3rd place winner is Tiffany Yu from Stanford University. Congratulations, Tiffany.
Thank you.
All right, and in 2nd place, we have Lyndon Walsh from McGill University.
Thank you.
And for our 1st place winner, we have Amy Feng from Johns Hopkins University. Congratulations to you and your team on an amazing presentation. And yeah, to our thank you to all of our presenters and all of our finalists. We did have a very competitive pool of abstracts this year. So we commend you on being here today. For our 3 winners, we will be in touch with you very, very soon to distribute the monetary prizes. Depending on what year you're in, I would highly recommend you consider saving it for Vislo, because those applications do carry a nice price tag, allegedly. And if no one has any closing remarks, we do want to be respectful of everyone's time. Thank you very much for coming to our 3rd annual research competition. We say this all the time, but these events are made better by you and the TSMA community. So thank you for coming. Thank you to our finalists for coming to teach us. Thank you to our judges for sharing their support and their insights. And if you don't already follow us on Twitter, please do that, because we have a lot of good events coming up in April, including a live cardiac dissection event on Friday, April 5, and a global cardiac surgery webinar on the 11th. So we'll be putting those up soon. If any of our judges have any closing remarks, we'd appreciate it. And thank you, everyone.
Just to keep up the good work, everyone. This was really great.
Yeah, congratulations, everyone. We look forward to seeing you at meetings. It's great.
All right. Take care, everyone. Enjoy the sunlight, and hope to see some of you at AATS soon. Take care. Thank you.
Carol.
Thank you.